Atrial flutter ECG and EPS. Flutter waves. Flutter waves are characterized by constant morphology, amplitude, polarity, and cycle length. Most prominent in inferior leads and V1. Sawtooth appearance is seen when the atrial electrical activity is continuous, without a defined isoelectric baseline between flutter waves. This is most notably seen in the inferior leads. To differentiate between atrial flutter and atrial fibrillation. In atrial flutter, the atrial activity waves, the flutter waves, have constant morphology, amplitude, polarity, and cycle length, while all these are variable in atrial activity waves during atrial fibrillation, the fibrillatory waves. The general rule is that if any part of the ECG shows variability in these items, the rhythm is atrial fibrillation, even if they look constant in other parts of the ECG. Flutter waves appear as follows. Counterclockwise atrial flutter. Flutter waves may be purely negative in inferior leads, but large positive in V1. Or, negative followed by equal positive component in inferior leads, but small positive in V1. Or, negative followed by larger positive component in inferior leads, but biphasic, positive then negative, in V1. Clockwise atrial flutter, broad positive in inferior leads, but broad negative in V1. Antiarrhythmic drugs. Slowing the atrial rate during atrial flutter by antiarrhythmic agents, such as class 1A and 1C drugs, can result in a paradoxical increase in the ventricular rate, caused by better AV node conduction of the slower flutter beats. If AV node conduction is improved to be 1:1, the ventricular rate will become very fast, and can result in hemodynamic collapse. This is why it is advisable to block the AV node, with drugs like beta blockers, verapamil, or diltiazem, before using drugs that reduce the flutter wave rate. The same rule applies when using class 1A and 1C antiarrhythmic drugs for atrial fibrillation, because these drugs may organize fibrillation into flutter with 1:1 conduction. Ventricular response. The ventricular rate in atrial flutter is usually a defined fraction of the atrial rate. The most common is a flutter rate of 300 per minute, with 2:1 or 4:1 conduction, generating a ventricular rate of 150 and 75 per minute, respectively. A general rule is that, with a narrow QRS complex tachycardia at a ventricular rate of 150 per minute, atrial flutter should always be considered. Here is a schematic of atrial flutter, with an atrial rate of 300 per minute, and 2:1 avenue conduction generating a ventricular rate of 150 per minute. Continuous 3:1 and 5:1 conduction ratios are very rare. In young children and rarely in adults, 1:1 avenue conduction may occur, which may be due to conduction in a bypass tract, or due to sympathetic activation, for example, during exercise. Variable AV conduction. Variable AV conduction is the result of multi-level block. For example, proximal 2:1 avenue block in the upper part of the AV node, with distal 3:2 Wenckebach block in the lower part of the AV node, or in the His bundle, result in 5:2 avenue Wenckebach block. This is commonly called atrial flutter with variable block. Terms like flutter fibrillation or fibrillo flutter are no more accepted. Alternating 2:1 and 4:1 conduction is common, generating a Bijgmini pattern. Finally, complete AV block can occur. Here is a schematic of atrial flutter with complete AV block. Both the atrial and ventricular rhythms are regular, but dissociated. Maneuvers. Carotid sinus massage in atrial flutter does not interrupt atrial flutter waves, but may be very helpful in distinguishing flutter from other arrhythmias because of a characteristic two-component response, impairment of AV node conduction, associated with acceleration of the atrial rate. Occasionally, carotid sinus massage converts the flutter to fibrillation. Valsalva maneuver may be used instead of carotid sinus massage. Adenosine may be used, 6 mg intravenously rapidly, followed by 12 mg if no response, followed by another 12 mg if no response. Intravenous verapamil, diltiazem, esmolol, or metoprolol may also be used. QRS morphology. The QRS complex during atrial flutter is often identical to that during sinus rhythm, but aberration can occur. Even with normal ventricular conduction, the QRS may be slightly distorted, acquiring a new or larger R, S, or Q waves, by superimposition of the flutter waves on different components of the QRS complexes. EPS in atrial flutter. A waves recorded during atrial flutter usually show rapid regular deflections with uniform amplitude and cycle lengths. In some patients, the A wave amplitude and cycle length are variable, in which case termination by atrial pacing is not usually possible. This form may represent an intermediate form in the arrhythmia spectrum, between atrial flutter and fibrillation. In the upper tracing, atrial flutter with uniform A waves is shown. In the lower tracing, variable A waves, thought to represent an intermediate form in the arrhythmia spectrum between atrial flutter and fibrillation, are shown. Atrial flutter features during EPS. During counterclockwise atrial flutter, the right atrial activation sequence occurs sequentially, up the atrial septum, over the right atrial roof, down the lateral wall adjacent to the crista terminalis, across the cavo-tricuspid isthmus, with some delay because of slow conduction across the isthmus, and finally past the coronary sinus opening. This sequence is reversed during clockwise atrial flutter. Flutter and fibrillation. Occasionally, the P-wave morphology on the surface ECG resembles classic atrial flutter, but intracardiac recordings show that parts of the atria, commonly the left atrium, have disorganized atrial activity. Such rhythms behave more like atrial fibrillation than flutter, but may be converted to true classic atrial flutter, with class 1 antiarrhythmic drugs or amiodarone. Despite this confusion, and probably overlap, for diagnostic purposes, the general rule still holds: if any part of the ECG shows variability in the P waves, the rhythm is atrial fibrillation, even if they look like constant flutter waves in other parts of the ECG. Programmed electrical stimulation during atrial flutter. Atrial flutter can be entrained, and can be terminated, by overdrive atrial pacing, by conduction block in the cavo-tricuspid isthmus, while termination by atrial extrastimulation is difficult. Detection of termination. Termination of counterclockwise atrial flutter, with high right atrial pacing, is detected by change of the negative flutter waves in the inferior lead suddenly into upright P waves, reflecting a change in the atrial activation sequence to one of high right atrial stimulation. Thank you.